The broadcast is now starting. All attendees are in listen-only mode.
Good afternoon, and thank you for joining the RLS Foundation's webinar titled Medications for RLS. My name is Zibby Crawford, and I'm the Marketing Coordinator at the RLS Foundation. Before we begin, please be aware that all attendees will remain on mute during this hour. We thank you for the questions submitted with your registration. Dr. Silber will answer as many questions as time allows at the conclusion of his presentation. After the webinar, you will receive an email with a link to the webinar recording. The recording will also be made available in the member portal of our website. If you are not a Foundation member and if you'd like to view this and other recorded webinars, we invite you to become a member today by going to www.rls.org. As always, individuals suspecting they may have RLS or are experiencing a change in their symptoms should always consult a qualified healthcare provider before making a change in their current treatment plan. Information offered in this webinar is for informational purposes and should not be considered as a substitute for the advice of a physician. Visit our website to find an RLS healthcare provider near you. Dr. Silber is a board-certified neurologist and sleep specialist at the Center for Sleep Medicine at Mayo Clinic in Rochester, Minnesota, an RLS quality care center. He also serves as a professor of neurology in Mayo Clinic College of Medicine and Science. Dr. Silber is an active member of the Foundation's Scientific and Medical Advisory Board and the current chair of the Opiates Committee. With a particular focus in neurology, his areas of research include the relationship of REM sleep behavior disorder to neurodegenerative diseases, drug management, and predisposing factors related to RLS, and epidemiology and pathogenesis of narcolepsy with special reference to the hypocretin system. Dr. Silber, we thank you for sharing your time and your expertise with us today. I now invite you to begin the presentation.
Thank you very much. It's a pleasure to be able to give this talk, which I hope will be helpful. We're going to talk today about medications for restless legs. The objectives of the talk are for you to understand at a little deeper level the use of medications to treat restless legs. And I'm going to be talking about iron, dopamine agonists, alpha-2 delta ligands, and opioids. I would like just to re-emphasize what you heard a little earlier, that nothing that I say should be considered as therapeutic suggestions for any individual patient. Please do not alter any of the medications you take. It may be helpful for you to discuss any changes you may envisage with your own physician. So we're going to talk about three categories of restless legs: intermittent restless legs, chronic persistent restless legs, and the difficult topic of refractory restless legs. I'm going to spend the least time talking about intermittent restless legs because I suspect that most people listening today have got more severe restless legs than this. Intermittent restless legs are restless legs that are troublesome enough to require treatment, but occur on average less than twice weekly. Well, if it's intermittent, we try first to avoid drug therapy altogether and use non-pharmacologic treatment, which I'll come back to in a moment. However, if we're going to use drugs, we use intermittent medications rather than taking them every day. And there's a choice your doctors have. For instance, if a couple of times a month you're troubled with restless legs at night and at the same time have a lot of insomnia related to active mind, maybe an intermittent use of a sleeping tablet, a benzodiazepine might be helpful. If you are troubled by restless legs, say on a long car journey or on a long plane flight, or occasionally when you go to, say, an opera in the evening, then the use of the medication called levodopa, which increases dopamine in the brain intermittently, might be very helpful. I would just caution, for reasons we'll come back to in a moment, we should never use levodopa every day because of the very high risk of causing the phenomenon called augmentation. And under some circumstances, your doctor may suggest the use of a low-potency opioid such as codeine to be given intermittently, so a number of choices. As regards non-drug therapy, I guess for most of you who are listening who've got more than mild restless legs, you've probably tried most of these things already. Clearly, one of the fundamental aspects of restless legs is relief by movement. So if you do get it on specific nights, walking, bicycling, rubbing, soaking the limbs may be helpful. It's interesting that many patients tell us that if they're just sitting back suffering, the legs are worse than if they do something mentally active, such as doing something on a computer or reading something interesting. It's a strange phenomenon that it becomes less severe, or at least more bearable with mental alerting. We recommend regular, moderate physical activity, a reduction in caffeine, and then we come to the controversial issue of what to do with drugs that can worsen restless legs. There are certain anti-nausea medications which reduce dopamine in the brain. The antihistamines that one buys in cold medications and things like that can worsen restless legs, and most antidepressants theoretically can. What I tell people on antidepressants is to ask, are we sure they are needed? And very often they are, for both anxiety and depression. And if they are needed and they're the best drugs for you, we work around it and treat the restless legs. However, many patients are put on an antidepressant and just left on that antidepressant year after year. And patients tell me, I don't know why I'm still taking it. I'm really not depressed at the moment, haven't been for several years. And then often a physician may be willing to consider taking one off it. But if you need it, you need to stay on it. There are certain leg vibration and compression devices on the market. I've never been terribly impressed with them, and I think the data that they work is not particularly good, but especially in difficult cases of restless legs or people who really don't want to use medications, they can be tried, but I don't think they're very successful for more severe cases in most people, though I do know of some considerable successes occasionally. Well, let's move on to the main topic today, which is chronic persistent restless legs. And we define that as restless legs, which is frequent and troublesome enough to require daily therapy. The symptoms are occurring at least twice a week and are causing moderate or severe distress. And some excellent studies in the United States and in Europe have suggested that about 2% of the population fall into this category. That's 1 in every 50 people. So we are dealing with a severe, common, and in some cases disabling disorder, as many of you know. So let's start with iron. I've summarized in this one slide what we know about iron and restless legs. The first thing is that some patients with restless legs, iron stores are reduced in the body, and sometimes there's a good reason: blood loss, such as from loss of blood in the stools for some bleeding in the stomach or the intestine, or more commonly in premenopausal women, menorrhagia, excessively heavy periods, and altruistic people who give blood very frequently may drop their iron levels as well. We know from MRI scans, those aren't ordinary MRI scans, they're specialized research MRI scans, and from autopsy studies in patients with restless legs who've passed away from other reasons and have altruistically donated their brains for research, we know from both these studies that there is reduced iron in areas of the brain in restless legs patients. We think the problem may be trouble transporting iron into the brain, though that's not certain for completely. How could low iron cause restless legs? Well, we know that iron is needed for the dopamine receptor in the brain, and we'll come back to that in a moment, to function properly, and that may be how iron interacts with dopamine and may cause low iron may cause restless legs. The problem is we have no good measure, except in certain research studies, of estimating what the iron stores are in the brain. So we can only really estimate iron stores in the body outside the brain by measuring certain things in the blood, and the most common thing we measure is something called serum ferritin, but it doesn't necessarily reflect what's going on in the brain. So let's talk about oral iron. The first thing is, This is not like a multivitamin. You should not take it unless iron levels are low in the body. You can take too much iron, and that can damage the liver. Now, serum ferritin normal levels depend on one's age and depends on one's gender. During adolescence, iron levels fall. In women who are premenopausal and who are having periods every month, iron levels are lower than in men or postmenopausal women. So the normal levels vary, but generally they're going to be between 10 and 25 micrograms per liter, and below that's considered iron deficiency. However, there are many people with restless legs who have normal iron according to that measure, but low normal. It's below 50 to 75 micrograms per liter. And there are studies suggesting that iron levels in that range, low normal, may cause or at least worsen restless legs. So as a restless legs physician, I'll consider oral iron replacement when I see restless legs patients with levels below 50 to 75. Of course, if it's really low, down 5 or 10, we've got to investigate and find out why the person is iron deficient. If iron is given, it should be given either once or twice daily. There's a little controversy about it. There's more recent work suggesting it might even be better to take it only once a day. And it shouldn't be given with meals, as it's very poorly absorbed into the body. And once you put food with it, it's even more poorly absorbed. We give vitamin C with each dose because that helps absorb it into the body. And I'll mention one proprietary preparation called Vitron C, which has both iron and vitamin C combined, and that's the one I recommend to patients because it makes it simpler than taking 2 tablets. Now, oral iron isn't without problems. You don't need a prescription, it's over the counter, but it can cause indigestion, constipation, and does often change the stools to a black color, which is disconcerting, though not harmful in itself. We don't give iron indefinitely. We would check the ferritin again every 3 to 6 months, and the goal again is to get it above 50 to 75. Now let's move on to new advances, and that's the use of intravenous iron. It's not really new. Intravenous iron was actually first used for restless legs in the 1950s, but fell completely into disrepute, and it's only in recent years we've begun to study this in more detail. I use it for one of the following 3 reasons. The first is the person's iron deficient or low normal iron, but they cannot absorb iron by mouth. Maybe they've had some surgery to their colons, or some bariatric surgery to the stomach, or got some disorder of the intestines which don't allow them to absorb iron. The second reason is, yes, they can absorb iron, but they can't tolerate it. Intense constipation or horrible indigestion, they really can't do it. And the third one is very severe symptoms, and we'll come back to that later when we talk about refractory restless legs, in which you really need to get them under control as soon as I can. Again, the iron level needs to be not high, and we have a cutoff of a ferritin less than 100. If the symptoms are severe and it's less than 100, we'll consider it. We also look at another measure called transferrin saturation. We want that less than 45% to be sure we're not overloading the liver by giving intravenous iron. I use 2 types of intravenous iron. The first is a low molecular weight iron dextran. This is the cheaper of the 2s, which is why I like it. It's 1 dose of 1,000 milligrams infused over 1 hour intravenously, but there is a risk, a low risk, but a risk of a serious allergic reaction called anaphylaxis, in which the blood pressure drops, the throat closes in, serious problem. So it's always got to be done in a doctor's office or an infusion center where there are people there who know how to treat this should it occur. And we give a 25 milligram test dose first. I must say I've never seen it myself, but it is reported. The other drug we use is ferric carboxy maltose. There are various ways of giving it. I use the European protocol of, again, a single dose injected quite rapidly over 20 minutes. The American protocol generally says 2 doses of 750 milligrams 2 weeks apart, but that's more expensive and the patient has to come back. It is more expensive, ferric carboxy maltose, but there are more studies on it than there are on iron dextran showing that it works for restless legs. Recently, at least in Minnesota, we weren't able to even get the iron dextran for several months, and we had to use the ferric carboxy maltose. Both seem reasonable approaches. This is not a miracle agent. I wish it was. I wish we had many miracles, but we don't. The success rate is about 60% for low normal iron stores in the range that I described. And surprisingly, it may take more than 6 weeks to be effective, and we don't understand that because we're giving it intravenously and hopefully it goes straight into the brain. If it works, that's great. The restless legs may come back 12 or weeks or longer afterwards, and you can repeat it if the first dose is successful. If it isn't successful, we probably usually don't give another go at it. All right, let's move on to the second group of drugs, the ones which until recently have been most used in restless legs management, the dopamine drugs. Now, what is dopamine? Dopamine is a neurotransmitter in the brain, a chemical in the brain associated with movement, with arousal, and the reward system, the system which rewards one for pleasurable things. So here at the bottom, there's a little picture of a nerve cell, a neuron, with a long tail called an axon, and that ends in a little swelling at the end. That's the end of the orange one, and you see there's a gap there, a black gap, and then there's another neuron at the bottom, a blue one, they've labeled it brain cell. Now, how the brain works is, of course, through electricity. So messages travel by electricity along this axon, but when they get to the end of it, they can't start the next brain cell firing. They've got to first release a chemical which crosses that gap called a synapse. That chemical, which is called a neurotransmitter, diffuses across the gap and then latches on to proteins on the second neuron, the blue one, and those proteins are called receptors because they receive the chemical. And the chemical we're dealing with here is dopamine. Okay, the drugs enhancing dopamine do work for restless legs. We're not quite sure what goes wrong in dopamine, but probably the dopamine receptors, those little orange boxes on the blue cell, may be reduced or not functioning properly. And therefore, if we give dopamine drugs, we can use every receptor that is functioning and increase the dopamine in the second brain cell you see there. So the drugs we use are called dopamine agonists. They are not dopamine themselves. They are chemicals which have been manufactured that look like dopamine, can be absorbed into the body from the intestine, can travel from the body into the brain across the barrier we call the blood-brain barrier and act in the brain. They confuse the brain, maybe that's the wrong word. They trick the brain into thinking they're dopamine, even though they're not exactly dopamine. There are two drugs which we've used by mouth, pramipexole and ropinirole. They bind to those receptors. They're both approved by the FDA for the treatment of restless legs, and numerous large, controlled, randomized trials have demonstrated they both work for restless legs. Generics are available, but perhaps the most important thing I can say is today we limit the maximum daily dose. Both these drugs are used for Parkinson's disease. That's their more common use. I should just say in passing that patients with restless legs do not have a greater risk of getting Parkinson's disease. It's coincidental that the same drugs work for both disorders. So we limit the maximum daily dose as much as possible to 0.75 milligrams daily for pramipexole and 4 milligrams for ropinirole. Ropinirole is so much more simply because the formulation is a little weaker. That's why it's more, but the two are pretty equivalent. The third drug available is the rotigotine transdermal patch. It's marketed as Nupro. It releases dopamine. This is applied once a day, again, very effective, approved by the FDA. You've got to be aware that skin reactions to the patch are common. Most often it's just a mild redness and itch and can be moved to a different site each day. But if there's actual breakdown of the skin, obviously it can't be used. The doses there are 1 milligram patches through 3 milligram patches daily. Well, how successful are these drugs? When they first came out in the 1990s, it was a miracle. We were struggling with our restless legs patients back then with inadequate medications, and suddenly these drugs just worked perfectly initially, and we thought the whole problem of restless legs was solved. Regrettably, that's not so. So if we look at the long-term use of these drugs, you'll see that they are about, firstly, how successful are they? Not as much as we thought at the beginning, not 100%. Every study has shown very similar results. Somewhere between 60 and 75% of patients are improved or very much improved. So again, regrettably, not miracle drugs, but work nicely in most people, at least initially. If we do long-term follow-up studies, here are 3 studies. The first one on the left is a study from Mayo Clinic on pramipexole, 50 patients who were followed for 10 years. And after 5 years, 90% were still on the drug. After 10 years, a pretty respectable number, 82% were still on the drug. The second study in the middle is from Hopkins. They had 164 patients, but after 5 years, only 58% were using the drug, and after 10 years, only 25%. And the reason of the difference is when the studies were done, the Hopkins approach was to take people off pramipexole as soon as any problem arose, whereas we tried to work with them and to use the drug as long as we could. So that's why the numbers are a bit discrepant. The third study from Europe is the rotigotine study and only went 5 years, but note that only 43% were using it after 5 years. Over half had discontinued it. So what are the problems? Well, there are some mild side effects. Some people get lightheaded or nauseous. You can get some congestion of the nose. Some people get leg swelling, and some people get sleepy. That's more of a problem in Parkinson's disease when the drug's used more during the day and in higher doses, but sleepiness mustn't be passed off. There are occasional people who get intensely sleepy on the drug and even can fall asleep driving with very little warning. That's unusual in restless legs, especially if it's used at night. But the main problem, of course, which is why these drugs are not used for years and years by most people, are 2 serious side effects. The first is augmentation, and the second are impulse control disorders, and we'll talk about each in turn. First, augmentation. This is the development of worsening restless legs with increasing doses of dopaminergic medication. And what happens is the symptoms spread earlier in the day, earlier symptoms by 2 to 4 hours. If you were getting symptoms in bed at night and taking pramipexole, say at 9 p.m., now they're coming at 6 p.m. or at 4 p.m. when you're sitting down. They can spread from the legs to the arms and trunk, and then what happens is the effect during the night, which was excellent at first, starts wearing off, and the more you increase the medication, the worse all 3 of these things occur. Let me give you a little case history, which I fear may resonate with at least some of you listening today. A 55-year-old woman had restless legs from age 19 years, experienced only in bed before sleep at night. 8 years before she came to see us, pramipexole was prescribed, initially 0.5 milligrams an hour before bed with good results. But over the years, symptoms worsened and the dose was slowly increased by her doctor to 0.5 milligrams on waking in the morning at 2 p.m. and at 5 p.m. and 2 milligrams before bed. By the time she came to see us, the total daily dose was 3.5 milligrams. You'll remember we don't like going above 0.75. And she says now restless legs is experienced whenever she sits down from 9 a.m. onwards, and she's only getting 3 to 4 hours sleep a night. Horrible augmentation. Well, how common is it? Here's a Hopkins study. I'd like you to concentrate on the brown line, which shows how many of their patients had discontinued the drug due to augmentation. And really, over 10 years, it was 7% every year discontinued it. So really, by the end of 10 years, 70% of their patients had augmentation. Here's the Mayo Clinic study. It was a little less. By 10 years, it was 42%. So I tell people they have a risk of somewhere between 40 and 70% of getting augmentation over 10 years. In our study, most augmentation occurred in the first 3 years, if it was going to happen. Little different results. Hard to know why there is a little discrepancy there. So what are the risk factors for augmentation? If you're going to start on pramipexole or ropinirole, well, the higher the dose goes, the greater the risk. The longer you've had symptoms and the longer you've been on these drugs, the higher the risk. Interestingly, if you also have low iron stores, there's an increased risk for augmentation. And if the symptoms were really severe before you started, there's an increased risk. And levodopa, which of course is the first dopamine drug I mentioned, the one we use sometimes for intermittent restless legs, has very high risk of augmentation, 80% probably, and that's why we never use it continuously and only intermittently when it's pretty safe. Rotigotine, well, at one point it was thought this is a safer drug for augmentation, and it may be so. In the 5-year study, augmentation occurred in 36%, which really isn't very different from pramipexole and ropinirole, but most of those patients, it was mild, and they were able to continue using it. Only 4% stopped it. So it may be that augmentation is a little less severe in rotigotine. Perhaps the slow release of the patch over 24 hours lowers the severity of the augmentation compared to sudden surges of dose when you take it by mouth, but that is speculative. The other serious complication are the impulse control disorders, and I hope most of you are familiar with those: pathologic gambling, compulsive shopping, and increased sexuality. And in our controlled study, you can see the percentage of patients who had it. It was not substantial by any means, and it didn't always start immediately. In our patients, it was 9 months later they started getting it. So patients have to remember that this can happen. And if it happens, we stop the drug, and it melts away. Often within 48 hours, patients cannot believe that a chemical could have caused what they regard as a psychiatric disturbance. But the important thing is not to say we'll never use the drug, but to remember these things. And if any of them start, report immediately to your doctor, and just recall that they are associated with the medications and are not due to some sudden psychiatric disturbance that's occurred in one. Okay, so if the dopamine agonists are not all that effective and have real trouble down the line, what else can we use? The second group are the calcium channel, we call them alpha-2 delta ligands, and the drugs are gabapentin, gabapentin enacarbil, which is a slow-release form of gabapentin given once a day, and pregabalin. These drugs do not cause augmentation. They do not cause impulse control disorders, but they are not without harm themselves, unfortunately. There are side effects, especially in older people: sleepiness, dizziness and unsteadiness. Weight gain may be a real problem in obese people. Leg swelling, a strange mental fogging, and depression can be worsened. And that's an important other one to recall. It doesn't mean we don't use the drugs in people with mild depression or in older people or people who are obese, but we're very careful in those situations. I will say most younger people don't have any of these side effects and tolerate them well, but not everybody. Okay, let's start with gabapentin. This is the cheapest. It's been around the longest. Funnily enough, it has the least evidence of working in restless legs, but there are controlled trials. It's not well absorbed into the body, very variably, so sometimes the dose we give doesn't necessarily reflect the amount that's in the body or the brain, but there's a wide range of dosing possible. I wouldn't worry about the numbers, but we can go from relatively low to fairly high. We start at lower than 900 milligrams. Generally, we'd start at 300 or maybe even 100 in an older person and build up slowly. Gabapentin enacarbil is a slow-release form of gabapentin, which is absorbed better. How successful is it? Very much like the dopamine agonists, somewhere around 65%, 70% effective. The dose is 600 milligrams once daily. Off-label, it has been used at 1,200, and it's FDA approved, but not generic. Pregabalin has been a big European study of 719 subjects. It showed it was at least as effective as pramipexole, but not taking into account the augmentation, just the other side effects, it had more side effects. It's better absorbed into the body, and I've listed the dose range. So, how can we prevent augmentation occurring? Firstly, don't use the dopamine agonists. So we today recommend to physicians consider alternative medications. If restless legs is infrequent, don't give every day. Use intermittent therapy. If you're going to use dopamine agonist therapy, use the doses as low as possible, remembering the cutoffs, and monitor for early detection, especially as duration of treatment increases, and keep iron stores replete, again, greater than 50 to 75. So here's the most important slide for physicians on how to start treating a new person with chronic persistent restless legs. There are two choices: the dopamine agonist or the alpha-2 delta ligand, such as gabapentin or pregabalin. Well, if starting on the right side, If the patient also has chronic pain for some reason, or the restless legs is the painful form, the alpha-2 delta ligand may be an ideal drug because it's also gabapentin and pregabalin are great for pain. If the person has a lot of anxiety, these drugs have been used to treat anxiety. If they also have insomnia at night due to an active mind, maybe a great drug as well, as they're sleep-inducing. And if the person's previously had a history of pathologic gambling or something like that, you'd be very reluctant to use the dopamine agonists. On the other hand, going to the left now, if this is really severe restless legs, the dopamine agonists we still think may be a little more effective. If the person's got ongoing depression, we'd be concerned about using gabapentin and pregabalin because it can worsen depression. And similarly, very obese patients or those with metabolic syndrome, that's having diabetes or at least a high sugar, high cholesterol, high triglycerides, we'd be a little concerned because of the weight gain effect of the alpha-2 delta ligands, and so we might start with the dopamine agonists. But if none of the above, and you're starting a new patient, today we will start with gabapentin in a carbo or pregabalin, and not with the dopamine agonists as we would have done even 5 years ago. So let's say you're on a dopamine agonist, and I've no doubt that many of you listening are on a dopamine agonist, and that's not unreasonable. It's a very standard form of treatment, but you now have developed augmentation. What do we do as physicians? Well, first we check the iron stores, and then if this is mild augmentation, you've come back to see us and said, you know, it's working fine at night, but now I'm getting it at 7 when I sit down in the evening. That's it. Well, let's say you're on 0.75 milligrams pramipexole. We might split the dose, give you 0.5 before bed, and give the other 0.25, say at 6 in the evening. We'd watch very carefully to see you didn't come back a month or two later and say, now it's coming on at 4 in the afternoon, and we wouldn't be above the 0.75. But if we haven't done that, we might try that for a while. Alternatively, we might say, well, let's take you off the pramipexole and try the rotigotine patch. As you remember, perhaps the augmentation is less severe on that. Or you might decide we've reached a point in which we don't really want to use dopamine agonists at all, and we'll change to an alpha-2 delta ligand. So that gets us to the third category, refractory restless legs. This is restless legs where we've tried both the drug classes. We've tried the dopamine agonist, we've tried the alpha-2 delta ligand, and it's unresponsive to one or the other monotherapy, meaning therapy with just one drug at a time, either because it's not working, or because on the dopamine agonist you got augmentation, or because either class of drug has caused other side effects, which means we really shouldn't use it. Whatever do we do then? And I regret to say that most of the patients I see today are in this category. So again, reassess the iron stores, consider intravenous iron therapy. What else could be worsening restless legs? Are they on antidepressants or antihistamines? Have they got sleep apnea that hasn't been diagnosed, that's waking them up at night and then the restless legs kicks in? We might consider combination therapy. Let's reduce the dopamine agonist down and add in an alpha-2 delta ligand together. So we're using double medication, but both in much lower doses. If all this doesn't work or isn't appropriate, we then say they're really refractory and we consider the use of opioids. And the rest of this talk, I'm going to spend a bit of time talking about opioids. So opioids are very effective for refractory restless legs, with studies showing persistent benefit for up to 10 years. They are remarkably well tolerated in the doses we use. There are 2% serious side effects, persistent vomiting, severe constipation. Doses are very low compared to chronic pain. Tolerance or dependence rates are far lower than with high-dose therapy for chronic pain. That is not to say it doesn't happen. I've seen it in several patients on relatively low doses, unexpectedly developing real problems with dependence, but it's relatively rare in my experience. There are a whole lot of opioids out there. We recommend the use of oxycodone, methadone, or morphine, but there are others. Oxycodone, the dose that I work on in most people, is 10 to 30 milligrams daily. Most people with chronic pain using it will be using 80 to several hundred milligrams daily. Methadone, we start at 2.5 and don't like going much above 10, though occasionally we do. And morphine has got its own dose schedule as well. So what are the side effects? Well, the first one that people sometimes get is itch. This is not an allergic reaction unless one gets hives. It's a side effect of the medication, can be quite troubling and difficult to manage. Constipation, one needs to adjust one's diet and sometimes take laxatives. Nausea and vomiting are fairly rare in the doses we use. Especially in older people, cognitive effects, people can feel their memory is not as good. They may, gait unsteadiness and falls is a real risk that we have to take into account. We do what we call a risk-benefit analysis. Is control of the restless legs worth the risk of falls? We tell people, especially older people, leave a light on at night in the hallway, hold on when you go to the bathroom, be careful. Opioids can worsen sleep apnea and change obstructive sleep apnea to central sleep apnea, so we monitor for this. Always a risk of overdose, either accidental or deliberate, and of course, as we mentioned, addiction. So I always assess the risk of addiction first. It's commoner in young, interestingly, white males, not quite sure why. Family history of alcohol, drug abuse, a personal past history of alcohol, drug abuse, psychiatric comorbidities. Now, it doesn't mean we don't use it in any of these people, but we monitor even more carefully. And there's a tool called the Opioid Risk Tool, which puts numbers to the various risk factors and tells you whether you're in a low, moderate, or high risk group. So what are the issues with opioids in restless legs? The first issue is a widespread confusion of restless legs and chronic pain, together with the very unfortunate widespread, I don't like the word epidemic, but the widespread prevalence of opioid addiction in the United States. And that prevalence comes partly from street drugs, heroin and others, and partly from excessive use by patients, excessive prescription by physicians of opioids for chronic pain. Historically, what happened was actually quite interesting. When I was a medical student and resident, we were taught never, never, never give opioids for chronic pain. They don't work and you can get addicted. And then maybe a decade or more ago, 10, maybe as much as 20 years ago now, there was a push from patients actually with chronic pain saying, we are entitled to relief of our pain. And as a result, pain began to be described as the fifth vital sign, you know, after temperature and heart rate and blood pressure, etc. And doctors were really encouraged to measure pain on a scale of 0 to 10 and treat pain until it was relieved. As a result, it became common use to prescribe these heavy opioids to relieve chronic pain, where studies have shown that they really don't work. It can even make chronic pain worse in some ways, and addiction is high. This was nobody's fault. It was a misunderstanding of what happened when you put large populations of people on opioids. It's been corrected. The pendulum has swung back. Opioids are no longer being used widely for chronic pain, but this has resulted in a huge amount of problems for patients who do need opioids in low dose, such as for restless legs. The first problem is insurance reimbursement issues. I think anyone who's put on opioids is going to have some problems needing to use whatever drug the insurance company requires first, pre-authorization, etc. A very severe provider's fear of professional consequences. Physicians out there are scared that if they prescribe opioids in the current climate, they will be reported to their state medical boards and will face severe professional consequences. And that's a real fear. We can't dismiss it, though I do think if physicians follow national guidelines, they do what's expected to be done in monitoring these patients, they have good reasons for giving it. I think the fear is somewhat unfounded, but I can understand it. And then problems with threatened restrictive administrative rules and legislation. Legislation which theoretically could limit the number of tablets you could get a month. Administrative rules from the FDA and other bodies limiting its use. I think we probably are not going to see draconic restrictions, but we have to keep aware of it, and I would encourage all of you to work with the Restless Legs Foundation to educate providers, insurance, and legislators, and the foundation has been proactive of this, multiple visits to Washington, they've been extremely good in trying to deal with these issues and educate legislators that restless legs is not chronic pain, the doses are lower, and we need carve-outs for restless legs in any proposed legislation. So what is responsible opioid use? When I have a patient I start on opioids, I first ask them to complete an opioid contract and sign it, which says basically no early refills, no replacement for lost prescriptions or drugs, though, you know, occasionally there's a story which really resonates with me, and of course we won't be draconic the first time round, but important, don't increase the dose without discussing with us. Agree that you'll get opioids from only one provider. We then tell our patients that we will do random urine drug screens. Generally, it's once a year, maybe once for 6 months for the high risk, but if we've got any suspicions, we might do it more frequently. We use the state prescription monitoring programs, which allow us to find out if the patient is getting opioids from anyone else, and frequent reassessment of response and side effects, usually 3 to 6 monthly visits. When I describe all this to a patient, I really try and be as understanding as possible and say this is not personal. We are not regarding you as a drug addict or a potential drug addict. You can understand with what's going on in the country how we've got to take simple precautions, and almost all my patients are quite understanding of it. I have heard of physicians out there who make the patient come in personally every 4 weeks to get the next prescription. I think that's overkill. I certainly don't recommend anything like that. I would like to say that it is our policy that we, like many centers, we do not treat opioids for patients who are out of state. The issues are just too complicated. We do give advice to patients, so I document everything clearly and send recommendations to local physicians, but we do not at our center, and I think many restless leg centers do not prescribe, actually take on for long-term care restless legs patients on opioids from out of state. And I know that this gives rise to some difficulties, but it's just how the system works at present. So I hope that has been helpful as an overview of how we're managing restless legs today. There's a lot of hope. There's a lot of things which work. Most of our patients, we do get relief. I do tell my patients that I cannot give them complete relief of restless legs, especially the more severe patients. I say my goal is to give you a reasonable night's sleep and a marked improvement in the quality of your life, but I cannot guarantee 100% control of restless legs by any means. And I try to emphasize the model of the cup half full rather than the cup half empty, and I think we get considerable success that way. So thank you for listening. I see we have time for questions, and I'll try and answer some of them.
All right, we really received a lot of questions. You've answered quite a few of them. The first is, after augmentation with a particular medication, can you ever use that medication again?
That's an excellent question. You've got augmentation, you take the person off it, try something else, a year passes, 2 years, and really it's not working well. Can't we go back to pramipexole again, or maybe to ropinirole, one of the other dopamine agonists? And the answer is yes, you can try. In general, our experience has been that augmentation rapidly develops again, and perhaps more rapidly than it did the first time. But as long as you're completely aware of what augmentation is and recognize the early symptoms and stop the drug when it happens, it can be tried, but it hasn't been greatly successful for us.
If morphine 30 milligrams ER plus gabapentin 1200 milligram is working fairly well, is it worth changing to methadone?
Well, I don't want to talk about specific doses and specific patients, but I would say if morphine at a reasonable dose, and both those drugs seem to be in reasonable doses, is working without significant side effects, I certainly wouldn't change. In general, consider changing to something else. I mean, if one has a success combination and the side effects aren't severe, I think be thankful one has a successful combination and keep something like methadone in reserve for the future.
All right. Is there any research on the efficacy of cannabis in relieving RLS symptoms?
I'm asked this constantly, of course. No, there is no research that I'm aware of. Cannabis research is very difficult because of restrictions on federal funding, and I'm not aware of any high quality research about cannabis and restless legs. I know of one physician who's used it and hasn't been terribly impressed with its use, but some patients tell me it helps, but no, there's no good data on it.
Is it okay to mix meds, gabapentin and clonazepam at the same time when your legs are really bad?
Yes, under supervision of a physician. It's okay to use two different categories of medications as long as they're not causing side effects. I would specifically not use clonazepam, which is a long-acting sleeping medication, benzodiazepine, together with opioids. They can suppress respiration. So that's one combination I wouldn't use, but gabapentin and clonazepam, as long as you're not getting too sleepy, works fine. I might just say that, you know, patients are maybe concerned about using opioids. It's going to drug them all day. But in general, my experience has been that if you're getting 1 to 3 hours sleep a night, and an opioid gives you 6 or 7 hours sleep a night, you feel more alert the next day rather than less alert. And the same might apply to gabapentin and other sedating medications, but all the classes of medications can cause sedation, and I'd caution everybody to be very careful driving in the early morning, especially at least as you're starting to take any of these medications, and especially as you're increasing doses.
Is it unusual to have RLS set in by noon, and how do you recommend I adjust my drug schedule?
Well, there are some people with severe restless legs who've never taken any medication at all, and it's there all day. That's unusual. One of the criteria for restless legs is that it's worse, at least in the evening and night than the morning. But there are people who do have severe restless legs all day. But if it's moved to the morning from the afternoon or evening, I would suspect that it's augmentation on dopamine agonists, and then one has to treat augmentation the way I outlined it. If you're not on dopamine medication and it's gone into the morning, we'd ask, has the iron stores dropped? Is there some other reason? But if there isn't, I might move to a drug that's used all day, that works all day, such as the slow-release form of gabapentin called gabapentin enacarbil, or the rotigotine patch. But that would depend on one's own individual circumstances.
Is Targan a suitable long-term treatment when all other medications have failed?
Now, Targan is actually oxycodone combined with naloxone. Naloxone's a drug which is supposed to reduce the risk of constipation with opioids. The big European study on oxycodone was actually done with this combination, but there were various reasons why they chose it. Even then, they had cases of constipation. So I don't think the naloxone adds anything to the efficacy of the drug in controlling restless legs. And if one's using non-generics, it's going to be vastly more expensive and probably not approved by insurance. And I don't see any advantage in this combination over ordinary oxycodone or OxyContin unless one has profound constipation.
Is there a recommended limit to the number of years one should be on any one of these drugs?
No, there isn't. It depends not on duration, but on what effect the drug's having. I've got patients who've been 15 years on pramipexole with not the slightest sign of augmentation, stayed steady dose, and it's fine, continue to use it. It's more whether one's getting symptoms of augmentation or other complications or side effects or the effects wearing off that would give rise to a change rather than an absolute number of years cut off.
I've had RLS my whole life, but it worsened during pregnancy. Is there any medication that's safe to take during pregnancy?
Well, an important question because restless legs does worsen in pregnancy. In 2015, a task force of the International Restless Legs study group put out a paper on treatment of restless legs in pregnancy, and I believe the foundation has a pamphlet on that as well. Ideally, one first addresses iron because iron can drop in pregnancy, and we're very aggressive in getting the iron as high as possible. We tell patients the best would be to use non-pharmacologic therapies. But if they're severe enough that it's really affecting the quality of life, there are some drugs that are recommended in that paper. I would recommend that any of you who are pregnant and are suffering from this should get hold of either that position paper or the Restless Legs Foundation pamphlet, and then take that to your obstetrician and discuss together what may be safe and acceptable. I would prefer not in this talk to talk about which drugs exactly were recommended by that paper, but there are some, especially in the second and third trimester, which were felt to be probably safe. We do not want to use the dopamine agonists or the gabapentin group during pregnancy, if at all possible.
Is there anything that can be done about nausea with dopamine agonists?
Yes, a minority of patients, thankfully a small minority, do get nauseous. You don't want to use conventional anti-nausea medication because that depletes dopamine, but there's a drug called ondansetron and a couple of others in the same class which work through another neurotransmitter called serotonin, and that would be the drug I would give with the dopamine agonist to try and relieve the nausea.
My doctor recently switched me from Mirapex to gabapentin. Now I wake up in the night. Would the extended form help?
Possibly. We have very little experience in restless legs with the extended form, and there's no... I'm sorry, yes, you're talking about the gabapentin enacarbal. I'm sorry, when you said extended form, I wasn't sure what you meant. The gabapentin enacarbal might well be a good drug to try, yes, because that will give you a slower release. Alternatively, sometimes a second dose in the middle of the night. But yes, you might well want to try. If gabapentin has been successful for half the night, you might want to try the gabapentin enacarbal.
Should I change medication regularly before I experience augmentation, or wait until augmentation happens?
There's no evidence that changing from one to the other in cycles works. If you're thinking of changing from a dopamine agonist to, say, gabapentin or pregabalin and back again, I think you're going to have a lot of trouble with that regimen. We tend to say stay on the drug you're on, be very aware of side effects and augmentation, and then make changes when that occurs early on, not waiting towards severe like that case history that I gave you.
The current thought connects low ferritin with RLS. However, iron injections for RLS is not FDA approved. Why not?
Well, unfortunately, the amount of data in high quality studies, large numbers of patients showing that iron therapy improves restless legs is not high enough to get FDA approval at present. That's basically the facts behind it. And unfortunately, iron is not exactly, I mean, it's not all generic, but the people making iron have not been prepared to put money into large major studies. So until those are done, the FDA is not going to approve it, which is unfortunate, but it's just a fact of life we have to live with.
What is the recommended protocol for switching from a dopaminergic drug to an alpha-2 delta drug?
Well, this is a little bit of a controversial subject. In general, what I do is I first put the person on the alpha-2 delta drug, build up the dose to a level that I think may be therapeutic before I start reducing the dopamine agonist, because patients who've been on high doses of pramipexole, ropinirole with horrible augmentation, it is going to get worse before it gets better. And if we simply take them off over a week or so, or a week or two, depending how the dose is, without covering something else, it can be a terribly traumatic experience with no sleep at all for days and days. So I like to get the person first on another drug and then reduce the dopamine agonist in the hope that it will cover that withdrawal period, which it doesn't always, but that's what I like to do. Not everybody agrees. in certain centers, they believe you should take the person off, and that the person needs to just realize it's going to be very uncomfortable for the first week, and then reestablish a baseline, because in a small minority of people with augmentation, when you take them off the dopamine agonist, eventually the symptoms may settle altogether and they may not need anything else. But in my experience, that's very rare, and I do not like my patients going through that withdrawal without something else. I think I should just mention that even with something else, that withdrawal can sometimes be very difficult indeed.
All right. Will over-the-counter drugs such as magnesium, folic acid, and iron help RLS symptoms even if the blood levels are normal?
Well, we've already talked about iron. Not a lot of evidence that magnesium or folic acid works for restless legs, and I do not generally recommend them.
Will RLS eventually go away with aging, or is this lifelong?
Well, most patients will have restless legs on and off through their life, assuming that this is a genetic form. 50% of restless legs patients, maybe 60%, have a family history. I'm not counting people who've got a secondary cause of restless legs, like iron deficiency or something like that, but people who've got just genetically determined restless legs. Most of them will, at the very best, have periods of severe restless legs. There are reports of remission, of people who go into remission for reasons we don't understand. Sometimes it recurs again, sometimes it doesn't. So there's always some hope that it will remit and that it isn't necessarily going to be lifelong, or at least not at the same intensity lifelong. So yes, it may improve for reasons we don't fully understand, but in many patients it does not.
Are there any antidepressants other than Wellbutrin that can be used while treating RLS?
Well, Wellbutrin is the one antidepressant which increases dopamine, and therefore that's the one we like. But of course, it doesn't work for everybody and isn't the most appropriate one. But I have many patients on other antidepressants that are theoretically supposed to worsen it, and they tell me it's no different from before I was on the antidepressant. I've stopped it and it makes no difference. I think in many people, the antidepressants don't play a large role. And what I usually say is depression's a serious illness, and if your psychiatrist feels that these are the best drugs for you and you must remain on them to keep your mental health stable, then we'll work around it. I don't want to take people off drugs they need for other health problems. On the other hand, as I mentioned, if you feel that you possibly don't need it under the supervision of the prescribing doctor, it makes sense to wean it and take you off it and see whether it improves the restless legs. But to answer the specific question, I don't know of any other drugs which specifically don't theoretically worsen restless legs other than bupropion.
How can I approach a medical provider about using some of the medications presented here today? Can you recommend any resources that would be helpful?
Yes, well, the Restless Legs Foundation, that's one of their major goals, is to educate providers. We have a lot of information. There are pamphlets. There's a full bulletin for physicians and medical providers about restless legs drugs in detail. We produced, as far as the opioids goes, we've published an article from the Medical and Scientific Advisory Board of the Restless Legs Foundation on the use of opioids. The foundation can either give you that or give you a reference to that article. So there's a lot of information available through the foundation. If you are a member, that can be taken to your provider, and I would encourage you to get hold of that information. A number of different, I mentioned the opioid ones, but we've over the years produced a number of different recommendation papers, both the foundation and the International Restless Legs Syndrome Study Group, that are available.
And I'd like to add that you don't have to be a member to call. We're happy to talk to anybody that needs information. I have taken a dopamine agonist or alpha-2 delta drug for 17 years. What is their long-term effect on mental acuity?
I don't think you should be worried, especially not the dopamine agonists. The alpha-2 delta drugs can sometimes cause a strange mental fogging, which is usually not permanent, but related to the drug that's in the brain at that time. I'm not aware of any good data that either drug will result in dementia or anything like that at all. If you need the drug, I'd continue it.
If I can't find a doctor to prescribe opioids, can a methadone clinic help me?
Probably not. I can't say that for sure, but methadone clinics deal with patients who are addicted to opioids. The idea is a lot of addiction psychiatrists believe that once you're addicted to opioids, you really can't ever come off them. So it's better to use long-acting, controlled medications like methadone, which physicians supply, and they monitor the patients in these methadone clinics rather than the patient gets dangerous drugs on the street. That's the role of a methadone clinic, and the psychiatrists and other practitioners who work in methadone clinics don't really know much generally about restless legs, and I'm not sure they'd be willing to take on patients with restless legs. Now, I can't say that with any certainty, but I think that's probably not going to, unfortunately, be a helpful area to go. You can try pain clinics, because pain clinics do work with chronic pain. My experience is many pain physicians, very competent and very committed, and physicians, compassionate physicians who manage pain. My jury, they don't know a lot about restless legs, but they could be educated, and I think some pain clinics might be prepared to prescribe for you. But generally, it's restless leg specialists and experts that you need, or neurologists who are prepared to treat neurologists or sleep specialists, even if they're not fully specialized in restless legs, who may be prepared to take you on. But I know it's become very difficult, and I understand it's a real challenge.
All right, well, that's all our time, and I wanted to thank Dr. Silber and for everyone that has joined us. Our next webinar will be on Monday, July 15th at 2 p.m. Dr. James Connor will be discussing basic RLS pathophysiology. So visit www.rls.org to register to attend. Thank you, everyone, and have a great day.